Welcome back to the Medical Report. For those of you who are just tuned in, we have today Dr. Towsen, who is an orthopedic surgeon from Chester County Orthopedics with a fellowship in sports medicine, or sports medicine and orthopedics. So we have just discussed a little bit about the disorders that can occur in the shoulder, and we're going to discuss on this session how to treat some of these things. So we're going to start with the more simple methods and simply the oral medications and things, anti-inflammatories and so forth, that you would use initially.
Okay. So the treatment algorithm for rotator cuff problems and some of the other issues we commonly treat in the shoulder is pretty similar. And as Dr. McCabe mentioned, one of the first steps often and one of the easiest things to do is to try an oral medication. And since many of the issues we're treating involve inflammation as part of the problem, whether that's tendinitis or whether there might actually be a torn tendon, there's often associated inflammation with that. So one goal is to try to decrease the inflammation, and there's a whole host of anti-inflammatory medicines, including things available over the counter, such as your simple Advil, Aleve, things that you have at home, I'm sure, and pick up at the store easily, as well as prescription versions of the anti-inflammatories, which are typically just stronger doses such that you can take a fewer number of pills and get a little bit stronger dose and a little better effect of the medicine to treat inflammation. And so our goal with the medication is to decrease inflammation, which should thereby decrease pain as well. We can use other types of medicines that are more directed just as pain, that are truly pain medicines and not anti-inflammatories, and there's a role for that at times, but our goal is to try to use as simple as possible a medication and something that will not be harmful. Unfortunately, the anti-inflammatories for many people are a little tough to take sometimes due to some stomach upset. And that's one of the most common side effects in the short term, so we are very sensitive to that and sometimes can't use those medicines as much as we might like to.
And then could you make the distinction between analgesia and anti-inflammatory? Some people mix that up.
Absolutely. Yeah, the goal behind an anti-inflammatory medicine is to do just that, is to shrink down inflammatory tissue, which is, if it's a tendon or a bursa, tissue that gets bigger, gets swollen, and we want to shrink that down. If that is the primary irritant, if that's really the problem, then by getting rid of that, we can also get rid of pain. However, if inflammation is not necessarily the cause of the pain, there are times where a true pain medicine that's not really working on inflammation, that's more of a narcotic pain medicine, is appropriate because the issue is not related to inflammation.
Yeah, that's good. Now, when you start somebody off on an oral medication, an anti-inflammatory, what is your rule of thumb as to the duration of time you're going to allow that to go on until you decide to do something else?
A lot of times we'll use that right off the bat in conjunction with another treatment, but if we're starting just with a medication, I would often like to give it at least 10 days, if not 2 weeks, or sometimes as long as 4 weeks, to really see if it's going to be effective. Many people will take anti-inflammatories here and there and not on a regular basis, and they can certainly work in that manner, but in order to truly get to a level in the bloodstream where it's being very effective as an anti-inflammatory, we will typically keep people on that for at least, like I said, at least 10 or maybe 14 days as a reasonable trial.
So you're looking for a sustained blood level rather
Yes.
than people will forget the medicine and wonder why it doesn't work.
Correct.
And they get one dose and it's gone. So you're looking for a sustained blood level over a period of time.
Yes.
Now, given failure of the oral medicines that you've talked about, what would be your next step?
Often we are able to do the same type of thing, meaning fight inflammation by using injectable medications, and some people are very much helped by a cortisone injection. Most people have heard of cortisone, which is a steroid medication, and a steroid is also an anti-inflammatory, but it's a stronger version of that type of medication. The oral medications we just spoke about were non-steroidal. There are also oral steroid medicines that can be taken, but they have more significant side effects, so we definitely try to stay away from those if we can. The injectable steroids are nice. Many people are very familiar with a cortisone injection. Many patients I see in the office for a first-time shoulder visit might have had cortisone for another problem. And again, it's an injectable steroid. It's an injectable anti-inflammatory that you'll put right in that spot, right in the location. You know, for our purposes today right around that rotator cuff issue in the shoulder there, and it works locally to decrease inflammation, so having the same effect that we talked about with the medication. It's a local injection, so it's not systemically absorbed. There are typically no significant side effects other than sometimes people get a little bit more painful for a day or so, when we call that a flare reaction, but that doesn't happen to everyone, and if that happens, it's temporary, and then the effect of the medicine is usually pretty quick acting after that.
Now, we've just discussed a little bit about anti-inflammatories for injuries that are inflammation. Now when we get into the point where there's some kind of a repair required and we get into the surgical aspect,
Yes.
Let's talk a little bit about what you do from a surgical perspective.
For a surgical treatment for a rotator cuff tear, and it's probably best to just focus on rotator cuff tears because more often than not the tendinitis and the bursitis issue, if not associated with a tear, can be treated without surgery. We can typically get that under control with either a medication, an injection, possibly some physical therapy, but when there is a tear, the tendon really has no ability to heal itself. So often if people have limitations, whether it be pain, weakness, lack of range of motion, or all of the above that are not being treated well enough with those other types of things, surgery becomes a very reasonable option. The surgery for rotator cuff repair has evolved a lot over the past 10 years or so, and now is really, by and large, an arthroscopic procedure. I have not done an open through a regular sort of big incision, if you will, rotator cuff repair in about 6 years. So I think there's certainly a role for it still, and some surgeons prefer to do it that way, but people who are trained to do the arthroscopic techniques can handle even the biggest tear arthroscopically, which makes it less invasive for the patient and usually makes the early part of the recovery a little bit easier.
Could you describe that instrument a little bit for our viewers?
Yeah, absolutely. Arthroscopic surgery is the minimally invasive technique, and we use an arthroscope, which is a small little instrument, a skinny little instrument, almost like this this device I have right here. This is actually an anchor, and we can talk about that in a minute, but the arthroscope is very skinny, and it has a little camera that sits on the end, and then we're actually able to insert that into the joint in this manner, more or less, and allows us to visualize the entire joint. And then while I'm doing the surgery, I have instruments in the joint, but I'm actually watching a TV screen across, not fully across the room, but on the other side of the table from where I'm working, and doing the surgery by viewing things on the TV screen. Then through just very tiny little incisions around the shoulder, it usually takes a few different incisions placed around the shoulder, we're able to use special arthroscopic instruments to get the same work done that we used to do through an open incision through some very small incisions by watching what we're doing on the screen.
And what can you get through this little cannula that you have here?
What I'm showing you is actually an anchor, and we use what are called anchors to repair the tendon. It's like a little screw that goes into the bone, and then there's stitches that we use to tie the tendon back down to the bone, because basically you would imagine that this edge here is lifted off of the bone and we need to reattach it. We do work through little hollow tubes, which are called cannulas, and we can put an instrument, again, something about the size of this, or thinking of maybe like a pen. Instruments are about that big, and we can put them through the cannulas, and we have different instruments that are aimed at performing different functions in order to get the repair done.
Now, this certainly is and how long does it take to do most of your procedures?
A standard arthroscopic rotator cuff for me takes about an hour to an hour and a half. So it is a relatively short time, and therefore a relatively short time under anesthesia, which is good. And then it is done as an outpatient, so our patients are able to go home the same day. It works out very nicely that way. The recovery period beyond that, including the physical therapy and the rehab, is not very different than what it was 10 years ago, and not any different whether it's done arthroscopically or open. But the minimally invasive nature of the arthroscopic procedure certainly causes less pain in the early days and weeks after surgery, and less disruption of the other muscles around the shoulder that we would typically have to dissect through to do an open surgery.
And what are your expected outcomes on these procedures?
We do get very nice recovery and results by and large. There is as high as a 30% incidence listed out in the literature of recurrence of rotator cuff tears even after surgical repair. So, and that might be a repair that never quite healed or possibly a re-tear. And there's a lot of gray area with that as well. But what I would say is there are a few factors that come into play that determine the outcome by and large. One would be the chronicity of the problem. We do see many people who have had long-standing issues with their rotator cuff and may have even had a tear for a long time and didn't really know it because they compensated well for it. But what that leads to is tissue degeneration, muscle atrophy, and sometimes tissue retraction, such that the tendon edge moves, if it belongs here, it moves way over here and is very hard to surgically get it back to here. So when the tendon retracts and the tissue is not as healthy as it once was, it can be hard to repair. Sometimes bone quality is an issue, particularly in the older population. If people are dealing with osteoporosis, when we need to insert anchors into the bone to reattach the tendon, sometimes the anchors don't hold well in the bone. So bone quality, tissue quality, muscle atrophy, those are all factors that come into play, and there are times where I can leave the operating room and know that the repair is great, is perfect, everything was the way it should be, the tissue was great, the bone quality was great, and there are certainly other times where I can say, well, we got a reasonable repair, but tissue quality wasn't as good as I had hoped for, you know, the bone quality was not as good, and sometimes, you know, the expectations are a little bit lower in that setting. And physical therapy following it is very important as well, and there's a protocol that we follow, and if people don't stick to that protocol, there can certainly be some issues as well.
That was going to be actually my next question. I think some people don't pay much attention to that suggestion that you would make in rehabilitation. And what would be an ideal setting? Should they go to a physical therapist, or will you give them exercises? How do you do that?
For rotator cuff repair, we have a very specific protocol, and I think it's absolutely essential that that a physical therapist be involved, and someone actually goes to formal physical therapy. At least, often it's for a couple of months at least, and then because we go through certain phases, first working on range of motion and then working on strengthening, but it's very important because early on a lot of the work needs to be done by the therapist as far as hands-on stretching, and then a lot of guidance is necessary as you proceed through the protocol. Once you're in the final phase, which is strengthening, many people are fine to do a lot of that on their own. Some people freely admit to me that the structure and the guidance of therapy and actually having to go somewhere and be responsible to someone makes it easier. But some people are very dedicated to do that on their own as well.
So when these folks start therapies, do they have pain?
Absolutely.
Yeah.
There is some. It varies. It does vary, but it's usually the first few weeks can be sore, and therapy days are typically, you know, more sore, and people need some pain medicine to help with that.
Yeah. Okay. Well, I think this has been very, very interesting. And do you have any other comments about this process from beginning to end? Do you have any observations you've made over the years?
Well, sure. The biggest thing I would say is that many people are scared of surgery of any type, which is understandable. Even the arthroscopic surgery can be a bit scary. But and then the thought of needing to be in therapy and recover for several months following surgery often will turn people away from it. What I would say is if you are limited by pain, lack of range of motion, weakness from a rotator cuff tear, and nothing else is helping, it's really worthwhile to consider the surgery, because people do gain much function back, and as they go through the rehab, they find that it's really, most often what I hear is that, you know, it wasn't as bad as I thought it was going to be. And I hear that enough times, and believe me, I have over the past several years, that I try to reassure patients both ahead of time and along the way that it's going to be worth it.
So, all in all, now, don't be afraid of surgery, so if you need it. And that's a very, very important point, and that's one of the reasons I brought up the physical therapy part of it. We thank you so much for joining us today, and I'm sure our viewers know a lot more about the shoulder than they did before we started, and we hope you enjoyed it. Stay tuned.
My pleasure.
And stay tuned to stay informed.